Okay, let's go ahead and shift gears again and take a look at the elbow, and we look at that as another type of a hinge joint that we perhaps can do an MWM on, Rick.
Right. So back to guidelines with our peripheral joints. When we think about elbow flexion and extension, we're moving in the sagittal plane. So in this situation, the glide direction is going to be at a right angle to the physiological motion. So in this situation, a primary glide that we use in the clinic is a lateral glide, again, to the sagittal plane. So the anatomy of the elbow is a little bit unique. It's not truly a pure hinge joint the way we may have learned in, say, high school anatomy. And what we do know, and especially in females, is that when they extend their arms, that there is that carrying angle, greater in females than males. So that's something that we have to take into consideration, is that in myself, not much carrying angle. Again, though, if it was a female, a lateral angle changes. So although it's initially here along my side, as we have a female that has an extensive carrying angle, we need to change that. That's another way of thinking about, a lot of times with MWMs, with the glides, that we have to adapt to the way that the person's moving. And so here's an anatomical fact that the actual physiological motion changes as you move into extension. And really, we don't have to worry about it, until the last 20, 30 degrees of extension. So let's go ahead and describe a picture that we're going to put on the screen. We're going to utilize a belt, and maybe you can walk us through that, Brian.
Just take a look at the screen there, folks, and you can see that our colleague Julie Polano has the belt around the patient's proximal radius and ulna. They're stabilizing inside the belt with one hand, just cupped against the distal humerus, just to stabilize and prevent the humerus from moving. You're going to provide a gentle lateral glide of that proximal radius and ulna as you move that person into extension or flexion, as the case may be.
Mobilization with movement at the elbow utilizing a belt. Very important with applying a lateral glide using a belt is that you realize that the force is coming through pushing back with your hips. You don't want to be too forceful. Also, the importance of keeping the belt at a right angle to the forearm. In this clip, you'll notice that I shift my hips, pelvis, just as the person goes into that end range extension, sustaining that glide the entire time.
Looks like a fairly straightforward technique, but there are some common mistakes that people make when they do this. You want to talk about that for a sec?
It's very important that you have the belt located as close as you can to the actual elbow joint. Frequently we see people have it too far out on the forearm. A simple question to ask your patient: if they tell you that it is painful, where's the pain coming from? It may simply be that you have the belt in the wrong place. You don't have the belt at a right angle. The belt may be pulled too hard. Also very important to make sure that, as we talked about, that you take into consideration the carrying angle. Yeah. Can you think of anything else I left off?
I think that's pretty good. Well, you want to also think about the amount of force, like you said, with the belt is critical, because if you got somebody and they're lying there and say, my little finger's starting to tingle, you got to watch out for that ulnar nerve as it comes through there, those kinds of things as well. So
that could simply be the edge of the belt, or that you're pulling too hard in that situation.
And that's a really common thing. I think that's probably one of the more common mistakes. People pull too hard and they don't have that right angle proper. Those are the two
and
things.
is overpressure still applied with this technique? Should you?
Absolutely.
Absolutely. All right. I think at this point it's time for us to move further up the upper extremity. So we're going to go ahead and move on to the glenohumeral joint and look at MWMs in the glenohumeral joint, the shoulder complex, and even the
AC joint.
AC joint. Thank you.
Sounds great.
There's the shoulder fixation, the scapular fixation. There's the location of my thenar eminence on the anterior part of the upper end of the humerus. It's below the coracoid process. I've tucked in there, and I'm going to move it at 30 degrees to this particular plane and slightly down. I sustain it, and our victim raises his arm sideways slowly. Reason for slowly, I can keep on target. Up he comes, all the way and down. Excellent. Of course, up again. That's perfect. Now, if he has no pain, there are other things we can.
So Brian, what if you're a really small patient, maybe a tiny woman, and you're working with a big football player or something like that, where you've got a mismatch with sizing? How do you deal with that then?
You would never teach a technique that everyone could not use. Now you get a great big football player and some small therapist. How can she reach around or reach up and reposition the bones? But don't worry, help is at hand. Thank you. Now, here we have a belt. The belt is placed around my thighs, upper thighs, and it should be comfortable. When I lean back, I'm now going to apply a dorsal glide.
So it's just the same glide that you did with your hands, but now you're using the belt.
The direction is slightly down. It's at 30 degrees. Here we are, just apply it. There's the fixation, 30 degrees. You've got a spare hand, just sort of just leave it there, just to, help the belt behave. And I just pull back. Can you feel that coming back?
Yes.
Goody. Now, while I'm doing that, could you please lift your arm up sideways? And as he comes up, you'll notice my body moves and down.
And then externally.
And up again. Oh, that's fine. Whatever movement's painful, you're going to see if the pain's disappeared when you put the belt.
And you're moving with him as he goes. You've got to move. And if you don't move, it blocks him.
Yes, it just will not function. Now, if this takes the pain away, how are you going to get a long-lasting effect? I think that if you can work the shoulder, use muscles of the shoulder, and make the shoulder function with some activity while the bones are correctly positioned, you bring the memory back to the joint. So that when it's done something for a while, it stays in position.
So we could add a little weight here to fire that rotator.
Yes, now, as we're going to do it, just watch what I'm going to do with him. There is the repositioning. You could add some weight, and he goes up. You can do this for me.
Yeah.
Yes, be useful. Up he goes.
Dumbbells in the clinic are handy.
Now, watch my hips. I have to move with him.
If we can shift gears just a little bit in terms of some MWMs for the shoulder area, what would happen, or I should say, what would you do, Brian, for a very specific AC problem? The patient that comes in and says, no, my problem is right here, very localized. Could you run us through a technique for that?
I'd love to.
Great.
Because I think I can tell the viewer of pathology that they might encounter. It's only rare, but you should be aware of it.
Right.
And that's a person that's got an AC joint lesion, and when they lift, abduct, they can't. They've got pain. They just can't lift. But ventrally, it goes all the way up.
Right.
Now, I can't believe this, but if you've got a patient, it's not common, but if you've got a patient that has this scenario, and you do what I'm about to show you, it'll give a click or a crunch or a crepitus, and they're instantly better. Stabilise the outer end of the clavicle. Now, while you're doing that, you ask the patient to swing their arm up freely. Now, where you stand is important, because if you stand here, you're in trouble.
Right.
They'll hit you.
What would the viewer need to know about what is the primary glide that you're inducing to the clavicle?
Well, in a way, it's a sort of rotation.
Okay.
It's a rotation. Now, a good point. When the arm is raised, the clavicle rotates.
Right.
It must. For the arm to come up, the clavicle rotates. I'm going to stop the clavicle from rotating. So what tends to happen is you get it's like a manipulation in that joint. It suddenly goes beyond the normal range of movement, and you hear a crepitus. And if you've got a...
So that's not necessarily a bad thing when we start actually hearing a little noise. It's moving again then.
No.